This patient has an ocular tumour. Although the eye being removed may at times be obvious, we would strongly encourage you to be in the habit of making additional pre-surgery checks on all eye removal surgery cases. In addition to the usual marking and checking of the patient before operating, it is also prudent to check recent eye clinic notes immediately pre-operatively. General anaesthetic is almost always used for enucleation. A peribulbar local anaesthetic with adrenaline is also given for its vasoconstrictive and analgesic effects. Careful attention to the sterile field is important because of the use of the ball implant in this procedure. The eye is thoroughly washed with 5% betadine, and a steri-drape, such as that used for cataract surgery, is placed to exclude the eyelashes. A small radial conjunctival relieving incision is made to allow a 360-degree conjunctival peritomy, which hugs the limbus. A small injection of subconjunctival local anaesthetic can make this step easier. A further radial conjunctival relaxing incision is made at 180 degrees to the initial one. This creates an upper and a lower conjunctival leaf that will be closed at the end of the procedure. Spring scissors are spread perpendicular to the globe in the subtenon's pocket in each quadrant. Then, in turn, each rectus muscle is hooked with a squint hook and secured with an absorbable 6/0 suture. Any of the numerous muscle suturing techniques that have been described for squint surgery can be used, as long as the suture is locked and will be able to securely attach the spread muscle to the ball implant. The sutures are placed on bulldog clips. The inferior oblique is hooked in the infratemporal quadrant. If this is difficult to find, it can be brought anteriorly by using a hand-over-hand technique with 2 pairs of non-toothed forceps to draw the tenons and then the inferior oblique anteriorly, as you see here. After checking the whole muscle is present, vigorous cautery is applied across it until the muscle is transected. Check that the whole muscle has been transected, as it is easy to miss some of it, as you see in this additional clip. The superior oblique is identified, cauterized, and transected in a similar manner. Each of the recti is then transected close to its insertion, although a stump is left at the two horizontal recti to enable traction later in the procedure. The globe is now attached only by the optic nerve and vessels. A 4-0 silk traction suture is passed back and forth through each of the two horizontal recti stumps, being very careful not to penetrate the globe, particularly in ocular tumour cases. In this video, the use of a snare for removing the globe is demonstrated. It is carefully fed over the globe, ensuring the extraocular muscles and tenons are outside the snare. Firm upwards traction is applied to the globe and the snare tightened. Alternatively, the optic nerve and vessels can be transected with scissors or cautery. The length of the removed optic nerve is very important in enucleation for ocular tumours. There is a small study reporting that a longer section of nerve is removed with a snare than cutting, although with careful attention to technique, a sizable section of optic nerve can be achieved with either technique. An orbital ball sizing set is used to determine the ball implant size. The normal globe takes up about 7.5 millilitres of the typical 30 milliliter volume orbit. A 20 millimeter implant has a volume of 3.5 millilitres, and a 22 millimeter implant 4.5 milliliters. A 20 or 22 millimeter implant usually fits comfortably in the adult orbit. And even in younger children enucleated for retinoblastoma, surprisingly a 20 milliliter implant is often comfortably accommodated. The posterior tenons is spread open with blunt scissors. Implants can be classified as porous or non-porous, and these have respective advantages and disadvantages, which should be weighed up for each patient. Currently, most porous implants are either made of hydroxyapatite or Medpor, which is a high-density polyethylene. A vicryl-wrapped bioceramic implant is being used in this case. The muscles will be sutured to the mesh. Other implants have pre-placed holes for suturing the muscles, or the holes can be made at the time of surgery. The implant is infused with saline and antibiotic by placing it in a 50 milliliter syringe of antibiotic solution and pulling the plunger in and out with the syringe opening occluded. Introduction of the ball with a Carter introducer is demonstrated in this video. The introducer allows the implant to be placed well within the cavity, minimizing the chance of dragging tenons with it, which may predispose to exposure. The assistant and scrub nurse apply upwards traction on the posterior tenons and the tines of the introducer carefully placed within the cavity. The introducer is then pressed and the ball is released into the tenons cavity. Posterior tenons is closed over the implant with a 6/0 absorbable suture, with the sutures taking a bite of the implant mesh. Each rectus muscle is sutured relatively close to the center of the implant with a 6/0 absorbable suture. Alternatively, the recti can be sutured directly to the implant, although the additional closure of posterior tenons does provide an additional protective layer. Anterior tenons is closed with a 6/0 absorbable suture. The conjunctiva is closed with a 7/0 absorbable suture. A conformer with antibiotic ointment on its posterior surface is placed to maintain the fornices until the cosmetic prosthesis can be fitted.